So I have to talk about the univentricular pathway. Not that we are fanatic about Fontan circulation in Melbourne. We try most of the time very hard to have a biventricular repair, but we do not go to the extreme that expressed by Pedro del Nido. I think we do not have the resources or the energy, and this is an exploration, a work in progress, and I think it's very good that one team is devoted to that investigation. So the title of my talk is "One Ventricle is Better Than Nothing." This is you've seen that slide before. However, I would like to, as I pointed out yesterday, we make a difference between unbalanced ventricles and uneven distribution of the common AV valve. And there are, as was pointed out by Dr. Del Nido, but also by my talk will remind you of some points developed by Dr. Obrutsky. So you'll see some that I have to go back onto these points. There is a significant literature of, as you have heard by Dr. Obrutsky, of trying to determine indexes that would be able to characterize the best patient for a biventricular repair and give some type of prognostic for a biventricular repair. Some of these papers are quoted here, and the indexes are multiple. You will see that there is a left ventricular width to ratio to left ventricular length. The common AV valve index, that is the size of the left AV valve, surface area of the left AV valve compared to the common AV valve, and so on. As you see that the right ventricle to left ventricular inflow angle, the left ventricular length compared to the right ventricular length, and the left ventricular width. All these are either a ratio between the left and right ventricle, or they are they use reference points that are mobile into the ventricle. They use a septum as a reference point, whereas the both cavities are working at same pressure. So these reference points are not relevant when you do have a biventricular repair. For example, the left ventricular inflow index, you can see that the reference is the tip of the septum. The tip of the septum it is there because that's where the septum finds its best equilibrium in the unrepaired position, but the tip of the septum could be further to the right. The tip of the septum also depends on how deep is the VSD. The VSD could be much lower. So that index is not very relevant once you have done a biventricular repair. Same for here. The right ventricular to left ventricular inflow in the angle. So this patient in that paper would be a very poor candidate for a biventricular repair, whereas this one should be. So you can see that if you have a less deep VSD, you would have a very suitable angle according to the authors. So what you need to have a biventricular repair is absolutely an appropriate left ventricular size and function. So the left ventricular size is the only criteria that is really absolute is the length of the left ventricle, the absolute length, and not in comparison to the right ventricle. You need an appropriate left AV valve size and function, and the left AV valve size depends on how much of the common AV valve you distribute to the left side. So with a precise surgical technique and a mandatory cleft, or you leave the cleft open in a mandatory fashion, you can keep the left AV valve very significant area, very significant. The unbalanced AVSD, it is a proportion, and proportion in all these indexes is not the absolute size, and the indexes are based on unreliable references point. I have explained that before. And what you have is the only significant and useful reference in our practice is the length of the left ventricle and not the ratio with the right ventricle. So the very precise VSD closure technique, I've explained that to you yesterday, so I won't dwell on that too much. But what is very important is to have to include in your repair a very significant coaptation surface that allows a very large seal, and you can have a competent valve without closing the cleft. Also, here you can see that the transfixion of the superior and inferior bridging leaflet, this level is determined by the surgeon. You can choose to septate the common AV valve at this level, but you could do it closer to the left edge, or you can do closer to the right AV valve. So you can create the size of the left AV valve you want. Here you have an example of a very clearly left dominant AV valve. You have almost the whole AV valve is into the left ventricle, and you can hardly see any AV valve opening into the right. This leads to using the criteria that I have described, a perfectly suitable biventricular repair. Another one is the right dominant common AV valve. So we have some tissue in the left side, but not so much. And that leads to a perfectly balanced repair. Another right dominant AV valve, hardly any tissue on the left side, and a very appropriate. This is the long axis, sorry. So you can see that, according to these indexes that have been described, this patient could not be septated, but you can see that the length of the ventricle is very suitable, and we have a perfectly balanced repair. Now, to go back to the original task that I have is univentricular pathway for AV septal defect with unbalanced ventricle. One ventricle is better than nothing. So when you have a short left ventricle, associated lesions, mostly hypoplastic aortic arch, or you have no or a hypoplastic left AV valve, you go straight to an orientation to a single ventricle pathway. So the length of the left ventricle would be about less than 80% of what you should require for biventricular repair. We have never tried the strategy that has been developed in front of you by Dr. Del Nido. What would be our strategy? In case of right ventricular dominance, we would treat them exactly like a hypoplastic left heart syndrome. So we do a pulmonary artery band if there is no subaortic obstruction. But if you have any kind of subaortic obstruction, or hint that the reduction of the volume loading would generate a subaortic obstruction, we would do damage arch and shunt. We reserve the term of Norwood operation to the hypoplastic left heart operation. So we would do that within the first 2 or 3 days of life. We do a BCPS at 3 months because it's very important to unload this ventricle as soon as possible, and a Fontan between 3 and 5 years of age. In case of left ventricular dominance, we have more leeway. So if there is subaortic or arterial obstruction, we would do a Damus arch and shunt. If there is no left-sided obstruction and no AV valve regurgitation, we would do a pulmonary artery band between 1 and 3 weeks of age. Then we would do a bidirectional cardiopulmonary connection later than the 3 months. We would do it when the patient requires it. So that might be 6 months, it might be 8 months, and we would generally leave the pulmonary stenosis and the pulmonary band. If there has been one. There is then the Fontan, we do it when the patient needs it, between 4 and 6 years of age, and sometimes a little bit later. So we have, for the purpose of this meeting, we have reviewed our patient 1976 to 2016, 30 years. So we have 139 patients with AV septal defect who went through the single ventricular pathway. We've excluded all the isomeric patients, so that's 37 patients remaining. An AV valve surgery was performed in 9 patients out of the 37. Second AV valve operation performed in 3 patients, and one of these 3 was a replacement, and no patient had a third AV valve procedure. This is the sex ratio, the ventricular dominance. Most of the patients are right ventricular dominant. There is a chromosomal anomaly in 6 patients. 4 patients had trisomy 21. This is in the old late time of the unit. We don't do that anymore. We don't. Very recently, we've been approached by a family with trisomy 21 and very unbalanced AV septal defect, and we recommended termination. Noonan syndrome is 1 patient, Bechtel is 1. Associated cardiac anomalies, you can see there the list, and greater than moderate patient at the first stage was 4 patients. Mortality according to the stage. So pulmonary artery band, 12 patients had a pulmonary artery band and 1 had the mortality. There were 11 Norwood procedure or Damus arch and shunt, and 4% mortality. 4 mortality, 36%. A BT shunt, what is that? No, sorry. 6 BT shunt, central shunt, 2 patients, 1 PDA ligation, and 1 pulmonary valvuloplasty. So 33 patients in total. Second stage, 16 patients had the BCPS, 5 patients had bilateral BCPS. That's 21 patients. So you have the mortality of the first stage plus the interstage mortality before. Stage 2, 20 patients had stage 3, 20 patients had the Fontan, and most of the patients are in the extracardiac conduit era, which is from 1996 onwards, with 1 mortality. The interstage mortality between stage 1 and 2, 10%, 3 out of 28. And between stage 2 and 3, 11%, 2 out of 18. The freedom from death, transplantation, and Fontan takedown in those who had a Fontan completion was 89%. This is the overall results, so that includes the before the Fontan, and you can see that most of the mortality is during the early stage at the time of the first stage palliation or the BCPS. Once they have the Fontan, the mortality is much less. The risk factors, the arch hypoplasia is the essential risk factor. When the patient have had a Fontan, the survival at 15 years over is greater than 80%, so 89% on the actual figures. We have presented and published a paper 3 or 4 years ago about the effect of the right ventricular dominance on the survival and the stage. And what we demonstrate, and that was our postulate, is that the effect of the right ventricular dominance is only when there is a volume loading, so before the Fontan completion. As soon as the Fontan completion is there, all ventricular anatomy are equivalent, and we have found in the Fontan registry in Australia and New Zealand, which now collects the data of 1,500, more than 1,500 Fontan patients. We do have that fact that at least initially, all anatomy are equivalent. The Fontan physiology is a predominant factor for mortality, but the hypoplastic left heart syndrome unveils its characteristic after 10 or 15 years, and higher hazard ratio. You have the hypoplastic left heart syndrome. This is the second phase of the Norwood procedure at the Children's Hospital. This is the left ventricular dominance. This is the right ventricular dominance. You can see that the mortality is really at the very early stage. If for the patient born after 2000, at that stage for the hypoplastic left heart syndrome, we do the bidirectional cardiopulmonary connection at 3 months precisely. And you can see that after the second stage palliation, the curves have exactly the same shape, so that the difference between these three curves relies on the before the BCPS stage. And this is demonstrated where you have in neonates, after neonatal surgery, the right ventricular dominance has a hazard ratio of almost 3, whereas after the BCPS, the dominance right ventricle do not have any significant hazard ratio. Now, to conclude, to outline the risk factor that is generated by the common AV valve in Fontan circulation. This is all 54 patients that have had a Fontan circulation in our unit with a common atrial valve. 54 no, that's 54 who had surgery, sorry. 54 patients had surgery. Out of these, eventually, you have 7 transplantations, 4 deaths, and lots of multiple surgery. So what we preconize now, what we advocate now in Fontan patients with common AV valve is preemptive surgery. So we try to prevent the dilation of the width of the common AV valve by a Gore-Tex band at the level of the narrowest portion of the common AV valve annulus, to try to prevent the almost mandatory failure of the common AV valve and need for reoperation or replacement. So in conclusion, patients with adequate size left ventricle should have a biventricular repair. The repair should be between 2 and 3 months of age. Failure to repair satisfactorily should lead to takedown and pulmonary artery band. This is a theoretical statement because we haven't had to do that. And the univentricular pathway, the actual survival is probably worse than the one of hypoplastic left heart syndrome, at least currently in our results. And the role of preventive or preemptive common AV valve surgery has to be investigated, and we are on the process of doing that. Thank you very much.